Good evening, one and all. Good evening, one and all. We welcome you all to the international webinar series on holistic health, well-being, and sustainable development 2022. Commemorating Azadi Ka Amrit Mahotsav, nation celebrating 75 years of independence in collaboration with Sri Holistic Health Foundation India and Sri Research Institute and Center for Art, Sciences and Well-being. We welcome you all. Before we proceed for the sessions, let's take the blessings of Almighty.
शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः
With the blessings of Almighty, we shall continue to today's session. Today, we are commemorating two events. One is Helen Keller's Day. She has contributed, she herself being blind and deaf, she contributed a lot to the education for persons with disabilities. And we are also commemorating Micro, Small and Medium Sized Enterprises Day today. So let's move on with our sessions for the day. Today we have with us distinguished Professor Ronaldo R. Donnell. He is a clinical professor, psychologist, and founding director of the Doctor of Behavioral Health program in the Arizona State University. He is senior global future scientist, Julie Ann Brigley Global Futures Laboratory, and has been providing lectures, consultations, and trainings on integrated care in China, Southeast Asia for more than 10 years, and now in Bangladesh and India. He is principal investigator on research grants studying integrated health in Thailand, Vietnam, and Cambodia, and a social worker training program in Arizona. He is collaborating with colleagues in Vietnam, China, and India to develop a curriculum to develop a new workforce of social workers for the integrated care. We welcome you, Professor Ronald. We are glad you are part of here and accepting our invitation. We feel very much delighted to be part of this wonderful webinar sessions where you are taking and sharing your insightful sessions with all of us. Thank you. Over to you for your session on integrated healthcare, a new approach to address lifestyle disease during and after the COVID-19 pandemic. Over to you, Professor.
Dr. Ravinda, thank you for a wonderful introduction, and thank you to the Sri Holistic Health Foundation and Research Institute for inviting me today. I really am very grateful for a chance to speak with all of you. I'll get my PowerPoint slide ready here.
Yeah, it's visible, Professor.
Very good. So my topic today is integrated healthcare, and I'll describe how I define that. It really means addressing in one place, in the hospital or a community health clinic, all the patient's healthcare needs, their medical needs. Do they have diabetes, hypertension? Do they have lifestyle problems underlying their medical problems like obesity, poor nutrition, lack of physical activity? Are they smoking tobacco? Are they drinking too much alcohol? Do they have psychiatric problems like depression, post-traumatic stress disorder? Many patients have all of these problems, chronic medical problems, lifestyle, poor habits that make their health worse over time, and psychological and drug and alcohol problems. How can we treat these problems in a way that's coordinated, systematic, that involves a team approach of both medical and behavioral providers? I've done this work for a long time, and my key focus now is training social workers. I know many people on this call are advocates for social work, and I think social workers are an excellent workforce to help learn these skills of integrated healthcare on top of their existing social work skills, and to help address this big problem we're facing globally. I always like to share my contact information and encourage any of you to contact me by email, WhatsApp, etc. So I'll leave this here for a moment. My background as a clinical psychologist, I spent many years seeing patients doing psychotherapy, adults, adolescents, children, as well as directing clinics and hospital units in USA, outpatient mental health clinics, for example, and drug and alcohol clinics. And then in 2008, I was recruited to help design and launch as director a new degree program called Doctor of Behavioral Health, which was designed exactly to create a new workforce of integrated healthcare clinicians. So the program has evolved. It's been very popular in the United States. It's an online education program, so we have students from all over the United States and other parts of the world enrolled. We enroll both clinical students, like Master of Social Work students, who then work toward their doctorate, as well as management students, say Masters in Public Health, Masters in Business Administration, who want to be leaders of integrated healthcare. My consulting work began in 2010. I was invited to do some work in China, and that grew over time. I worked with a business colleague there to make several visits each year to train physicians and nurses, psychiatrists, and social workers on integrated healthcare. Over time, I expanded my work through networking to Southeast Asia, Vietnam, Thailand, Cambodia, and more recently began working with Cyber University and a couple other universities in India. So I'm happy to see my work continuing and spreading. My research experience includes a large grant in Arizona to train social workers in integrated healthcare. That's a 4-year, $2.5 million USD grant that's in year 1. I have several global projects on studying integrated healthcare right now with projects in Thailand, Vietnam, and Cambodia. And also, especially relevant for this presentation, I'm doing a grant with the University of Labor and Social Affairs School of Social Work in Hanoi, Vietnam, developing a curriculum, a class, and a companion textbook for integrated healthcare for social workers in Vietnam. These photos are me doing my bike riding in Thailand with my students visiting Cambodia, my good colleague in Bangkok, and then my colleagues from the Center for Disease Control and Prevention in Guangzhou, China. Here's a quick listing of current partners I've been working with over the last 2 or 3 years and currently, and looking forward to add new partners in India. So if any of you want to collaborate, I'll be happy to arrange a time to talk by Zoom in more detail about possible collaboration. So now the problem we're facing, we have a triple pandemic, a triple epidemic globally, and especially in India. We have COVID-19, which we thought would be going away by now. It's not going away. COVID-19 is here to stay for the foreseeable future. The good news is that the current variants are less deadly than the first initial variant. The mortality is decreasing in USA, but infections continue, and people are still worried. People are still suffering because of the supply chain problems globally. So COVID-19 is a problem that's come on the scene, and it's led to great problems globally. Non-communicable diseases, NCDs, like diabetes, hypertension, cancer, are all increasing globally. And mental health problems, depression, anxiety, alcohol problems are also increasing globally. We know for COVID-19, if you have a non-communicable disease like high blood pressure, like diabetes, and become infected with COVID-19, your risk for poor outcome, including being sicker or dying, are much greater. So just having chronic medical conditions makes you at greater risk for poor outcomes for COVID-19. So it's to our advantage as a country, as a society, to find ways to reduce NCDs, to avoid poor outcomes of COVID-19 if you are infected. We know that non-communicable diseases are largely caused by health behaviors. The things we do cause diabetes, cause hypertension, in particular unhealthy eating, smoking tobacco, especially for men, of course, a lack of physical activity. We're all spending more time in our chairs, in front of our computer screens. We're spending more time watching streaming media, watching movies, TV shows, series, watching our Facebook and our social media accounts. And of course, excess alcohol, also especially for men. These health behaviors are a key cause for many non-communicable diseases. And if you have diabetes, hypertension, and keep on eating poorly, smoking, drinking too much alcohol, even with medication, you're going to have over time more and more complications. We know that COVID-19 has caused a global increase in anxiety and depression. The United States and other countries also, we're seeing, because of the stress of lockdowns, loss of income, loss of jobs, fear of infection, loss of loved ones, many uncertainties in life. We're seeing ongoing increased depression and anxiety globally. What do we do about that? How can we address anxiety and depression, especially in India, where there's still a very strong stigma about admitting you have a problem like depression? How do you deal with that? It's growing up, but we lack the approach to treat it effectively. So we have, in summary, a health problem where we have increasing NCDs, non-communicable diseases, that are caused by lifestyle behaviors. We know that psychiatric and substance use disorders are very comorbid. They're very frequent with chronic disease. If you have diabetes, it's very common to have depression also. And that COVID-19 now is increasing the risk for poor health outcomes if you have NCD. We have a workforce problem too, because we have a large workforce of physicians and nurses globally, but they're stretched to the limit. They're just taking care of many patients with acute medical needs. They see a high volume of patients. They typically use only medication, pharmacotherapy, as the first and only intervention. This workforce of physicians and nurses, well dedicated and well trained, they are not typically trained in how do you counsel a patient to actually stop smoking, to lose weight, to eat healthier, to be more physically active. If you ever try to change one of your poor health habits, you know it's very difficult. It's hard to change our habits. And a physician or a nurse with a 2 or 3 minute visit with a patient simply hasn't the time or the training to offer that kind of behavior change health coaching. They're very busy with their own productivity demands to see so many patients per day, to make sure they give out medications appropriately, to refer for labs and specialty care. So a workforce problem needs to be addressed. And last of all, technology problem. We're seeing a fantastic growth of digital health technologies, things like smartphone apps for helping patients to learn about diabetes, hypertension, depression, wearables like a smartwatch or activity trackers like your Fitbit. You can wear and have real-time information about your daily physical activity, about your sleep patterns. And we're increasingly seeing remote Bluetooth-enabled devices to have the patient track at home their health for things like blood pressure cuffs for hypertension, blood glucose machines for diabetes, even having a weight scale, Bluetooth for BMI. So we're seeing the cost of technology come down, but we're not seeing our physician and nursing workforce recommend these tools to patients. So the good news is technology is becoming more available, lower cost. Many apps are free. The bad news is it's still difficult to encourage patients to use these tools to help improve their health. So one solution I'm working on is to have social workers become a new workforce for integrated healthcare globally. Have social workers trained to be able to be a health coach, to talk to patients, give them education about their medical diagnoses. You have hypertension. Here's what that means. Here's what your blood pressure measure means. Here's the kind of risk you'll face in the future, stroke, heart disease, if you don't improve your health now and better manage hypertension. Oh, it seems like you have depression. Let me talk about some ways you can help address depression. Or better yet, don't even use the word depression. Say you seem to have a lot of stress. There's less stigma when you say you have stress. We all have stress in life, right? So it's a chance to really communicate with the patient about psychiatric mental health concerns without raising the terms that cause stigma. And of course, they can offer health coaching on, well, how can you become more physically active? How can you eat healthier foods? Social workers already have good skills in patient interaction. They already have good skills for patient advocacy. The training to have them become skilled at integrated health interventions is not too difficult of a leap. And I believe very strongly we can help make that leap for social workers in India. So just a definition of integrated behavioral health. It's a practice team of primary care, medical, and behavioral health clinicians like social workers or psychologists, working together with patients and families, using a systematic approach to provide patient-centered care. The patient, their needs are the center of care between the team of medical and behavioral providers. This may address mental health problems like depression, alcohol problems, stress, and health behaviors that contribute to chronic medical diseases. So in essence, the social worker becomes a one-stop shopping source for patients, resource. They can help educate about diabetes and heart disease. Of course, the physician and nurse is still the expert on treatment and providing medication, but the social worker's role is to help educate patients what the diagnosis means, what the risks are in the future. We know that many patients in India aren't even aware they have a diagnosis of diabetes, hypertension. If they are aware, they don't feel any physical symptoms in the early stage, so they think, I'm okay, I don't need medication, I have no symptoms, I'm not going to take this medication the doctor gave to me. I already mentioned depression, anxiety, alcohol, stress, all very big problems for the population, and stigma makes it hard to get care. And then lifestyle, again, we know overeating, poor nutrition, lack of physical activity are leading to obesity in India. So I'm working with my colleague, a faculty professor at University of Labor and Social Affairs in Hanoi. Her name is Dr. An. Feel free to copy her information for her email address here. We're now working on finalizing a course for social workers in integrated healthcare that she'll teach this fall. We're finalizing a textbook we're writing to go along with the course, relatively short, about 200 pages, a very practical book of different kinds of activities to teach social workers, not just research and theory. It's full of hands-on learning activities. And my hope is we can take the same curriculum we're developing in Vietnam and adapt it, of course, for the Indian healthcare culture and patient culture. So here's some of the summary of the curriculum: Introduction to Integrated Healthcare, the role of the social worker in integrated healthcare. I recognize that right now, the role of the social workers in India is not the same as the United States. In the United States, 10 years ago, there were very few social workers working in the United States in primary care clinics with the family doctor. Now, 10 years later, there's been a great movement to have social workers be trained to work with the family doctor, to work in their clinic, to work in an exam room, and see patients that the physician refers to them at the same moment they're seen by the physician. The doctor sees the patient, walks them down the hall, introduces the social worker. The social worker shakes their hand and begins talking about their assessment and their health needs. Screening and assessment, how do you screen, identify quickly and easily what the patient's problems are? Especially with an aging population, more patients have multiple problems. Maybe the patient has diabetes, plus obesity, plus alcohol abuse, plus depression. We can use very short screening questionnaires like the PHQ-9 questionnaire for depression, similar short questionnaires for nutrition, physical activity. We can look at the medical record for things like blood pressure, blood sugar, BMI for weight. We screen and find out what kind of problems does the patient have? How severe are they? Then we try to introduce treatment strategies, behavioral approaches to address all these problems. Education for medical problems, behavior change for lifestyle problems, psychotherapy, brief psychotherapy for psychological problems. And of course, team-based consultation is great. I know most social workers in India work in the community. They don't work with the family doctor, and that's okay. You can still do work with the patient in their community on these topics, helping to develop community education groups, community behavior change education groups. And you can still communicate with the physician just by email, phone call, or text to tell them what you're doing. You can recommend for patients that have the means using smartphone apps. I know in many poor parts of India, patients cannot afford smartphones or activity trackers or smartwatches. But even there, you can use old paper and pencil versions to have them self-monitor and change their health behaviors. Here's an example of one of the modules for screening and assessment. We train the social worker to look at the medical record and find out what their obesity is based on BMI, body mass index, or waist circumference, how to understand what the different measures of blood pressure are, what is mild, moderate, and severe hypertension. Same thing for diabetes. What is the blood glucose measure indicating prediabetes or diabetes? What are the cholesterol levels? These are all things that we want the social worker to understand what these numbers mean and how to explain to the patient how these high numbers for medical problems can lead to very big problems in the future. Oftentimes the patient really can't envision that. You have to say, do you have any older relatives that had hypertension and diabetes? Anyone who had a stroke from hypertension? Anybody that had blindness or foot amputation from diabetes? When you give examples of what might happen to them, the patients are much more motivated to try and change. I mentioned self-report questionnaires, paper and pencil. You can even have them be on your smartphone app for depression, anxiety, post-traumatic stress disorder, physical symptoms. We know in Asia, many patients experience physical symptoms as a sign of stress. I have a headache, I have a stomach ache, I'm tired, I'm not sleeping well, I'm fatigued, I have no motivation. This is how patients often express emotional and psychological upset in Asia, not by saying I have a depressed mood. There's too much stigma for that. So physical symptoms are also a key indicator, and we have questionnaires to assess those. So we try to do a screening and an assessment, identifying all the key problem areas the patient has, how severe they are. Then we want to offer for those who have psychological problems, treatment that is brief. We know that people are very busy in India. They haven't got time for long therapy meetings over many weeks. We need interventions that are brief, but also effective and evidence-based, not just for evidence-based in the United States, but evidence-based for India. So brief interventions include motivational interviewing, a technique to help use communication, use the dialogue between the social worker and the patient to help the patient on their own speak more about their motivation. Have the patient lead increasing motivation through your conversation. Asking questions help the patient identify why they should change and overcome barriers to change. For depression, behavioral activation is a widely used technique that is much shorter than things like cognitive behavioral therapy. only takes 3, 4, or 5 sessions, but as effective. And the goal is to get the patient more active. When they're more active, their mood typically improves. Problem-solving therapy is a brief intervention to help patients solve problems, including in barriers to care. Cognitive behavioral therapy, the full model takes 12, 13, 14, 15 sessions, probably is not feasible, but a short, brief model of CBT is. Mindfulness meditation, increasingly popular globally. Of course, meditation was founded in India, right? Through Buddhism. And mindfulness meditation is an approach that has been adapted and developed in the United States and now applied globally. We're typically in 6 to 8 group sessions of education and practice. Patients use mindfulness to address emotional upset and emotional problems. So it's a very structured approach that can be taught in an educational group. We have screening, brief intervention for alcohol problems. And of course, traditional medicine. We try to incorporate wherever possible the existing patient beliefs. So in India, if your patient believes in Ayurveda medicine, of course, that can be a great framework for integrated healthcare, because Ayurveda medicine, it does focus on better management of stress, better healthy eating, using physical activity to stay active and improve your mood. Yoga is also good both for physical activity and for stress. So we try to find interventions that are brief and that fit the population's belief system. For medical problems, again, it's important the social worker has at least a basic knowledge of common medical diagnoses, how they are caused, what the progression is over time, how they get worse, what kind of treatments are available, typically medications. Insomnia, of course, insomnia is increasing globally, in part because of stress, in part because people are just working longer, having more stress to deal with their family. So insomnia is a problem that needs to be addressed. And health coaching can be used for all of these problems to improve medication adherence, to use habit change techniques to increase physical activity, eat healthier foods, and to eat more fruits and vegetables, reduce high-fat foods, reduce high-sodium, high-salt foods. How to stop smoking tobacco is very difficult, but very important. So these are all things a social worker can be trained to do to educate the patient about medical problems, but also become a health coach to help them address these problems. The 5 A's is the framework. The 5 A's stands for the 5 steps of assess, advise, agree, assist, and arrange. In the assess phase, you do the screening, right? You find out all the key problems the patient's experiencing. Then you offer them advice based upon your training and experience. Maybe it's medication for diabetes. Maybe it's an alcohol management program for alcohol abuse. Maybe it's behavior activation for depression. But you explain to the patient what the problem is based on your assessment and give them advice what the options are for treatment, including the pros and cons. What are the advantages of medication? What are disadvantages of medication? Are there side effects? Can the patient afford medication? Once you have the patient understand their options, you ask them, after you advise them, to agree, what do you want to start for your treatment? Maybe you want to say medication for diabetes is one choice. Physical activity might help. Improving your eating, stop smoking. Which one are you most interested and motivated to start with? Use the patient as a guide, because if the patient chooses the goal, the topic, the odds are greater they'll be successful. They can pick the problem they're most motivated, most ready. Maybe they'll say, I want to start working on stopping smoking first. That really is bothering me. But I want to do physical activity first. We then use motivational interviewing to help the patient find the reasons to change, to amplify those, make those more clear, to increase in their mind the clarity of what are the advantages of changing? What are the disadvantages of staying the same? I mentioned already mindfulness for stress and resilience. I've been doing mindfulness myself for maybe 6, 7 years now. I find it very good for all the stress I experience in life. And then behavior activation, for example, is a treatment for depression or stress. Additional training models. How do you improve nutrition, physical activity? There are increasingly models of habit change being used that are designed to be very practical, very efficient. So you want to eat healthier. Let's start small with one little goal. How about adding one vegetable or one fruit to your diet, maybe at lunchtime? You take your existing habit. I typically have lunch at work during my break. Okay, can you bring an apple, a vegetable, a fruit to work with you and have that on your desk as a reminder? So very small, and try and have the habit done every day for 1 or 2 minutes. We find that you can build habits by being very small in your goals, so it's realistic. In the process, I'm becoming a healthier eater, not the goal of I'm going to lose weight. The goal is I'll become a healthier eater. So we train social workers in these emerging new models of habit change. And then for complex patients, how do you help them when they have multiple problems? You can't work on 5 or 6 problems at once. You can't try and take medication and stop smoking and reduce alcohol and exercise more. You must pick and work on them one at a time over time. And it takes time. If you want to change a habit, it takes a few months at the best, maybe an entire year to change the habit. And our goal here is not to make a quick fix, but to actually have the patient make permanent change in their life. We call that conditioned self-management. I'm learning to manage my own health on my own by monitoring my health, my physical health, my mental health. And if I see a need, doing things every day to help me better manage my health. I weigh myself every day to watch my weight. I meditate every day to manage my stress. I take medication every day to make sure that my symptoms don't get worse from hypertension. These are all examples of things we do to offer training programs for social workers. So of course, there are many barriers to integrated healthcare globally and in India. Number one, lack of financial resources. Right now, for example, while there is government funding in the United States to have social workers work in primary care with the family doctor, that's not the case in India. There's no funding to have social workers working in the primary care clinic or the community health center. We have social workers in hospitals in India. That's a great place to start. We have social workers in the community who can still do integrated healthcare in the community with patients directly. So we have to find ways to adapt. And also for the longer term, trying to find things like pilot projects or small grant funding so we can show if you put a social worker trained integrated healthcare into the primary care clinic, it's going to result in improved health outcomes. We had the challenge of adapting integrated healthcare to the healthcare system and patient culture. The healthcare system, being physicians and nurses, often don't value social workers. They can't help me. I've got busy patients with medical problems. The social worker, they don't really offer much help, much benefit to me. They're held in low esteem. That was the case in the United States years ago too, but now if we place a social worker in a primary care clinic, the physician might say at first, well, I'm not sure how they can help me, but I'll bring them on board, okay. Then slowly after weeks where the social worker educates the physician, began screening patients for different kind of health problems, begins helping the patient become medication adherent. Suddenly the physician's perception of the social worker improves. They see him as more valuable. Oftentimes we place our students for a 2-semester internship with a physician. When the internship is almost over, the physician says, please, can you have the social worker stay longer? Can we hire them? Because they value the work so much over time. But it's hard. It takes first educating and showing the physician and nurses what the social worker can offer to the practice. We need to assess what are the current skills for integrated healthcare for social workers in India. Right now, of course, it's very low. It's not part of their training and education. So I'm working now with Cyber University and other universities to train social workers in integrated healthcare techniques, to measure their competency using a competency assessment questionnaire developed in the United States. So we can see before and after training, are they getting the skills they need to help do integrated healthcare in India? So on the right-hand side, those are the barriers. Facilitators, we know the social work education as it is right now for Masters of Social Work is very well suited for patient engagement, patient advocacy, doing patient work in the community. So it's not difficult to train them in new and additional skills to become a health coach, health educator. We need to have increased recognition by leaders, like, for example, Ministry of Health, about the need for addressing non-communicable diseases. Now, the good news is most healthcare government officials recognize in India that non-communicable diseases are increasing. and is costing the healthcare system more and more money as a percentage of gross domestic product, GDP. That's not a good thing. The more a country spends on India, on hospitalizations, on medications, on complications for chronic disease, that drags down the rest of the economy. So we know integrated healthcare, when you improve medication adherence, when you reduce obesity, when you reduce smoking and alcohol, there's a cost savings. Those patients are more productive at work. They're more productive with their family. They're not using the hospital as much, not using medication as much. There's a decreased cost, which is a great selling point for government officials. We need local champions, and we have them already. Social work faculty I'm working with now who want to see integrated healthcare become more common in India, in Bangladesh, in Sri Lanka, in Vietnam, in Thailand, in Cambodia, and in China. So we're seeing local champions help to promote this. And of course, there's a stakeholder interest. When I talk to physicians who are very busy, they know patients need advice on smoking cessation. They know patients need to increase their physical activity and decrease unhealthy eating. They're aware of this, but they also know they're too busy and not trained to do these things. So they would welcome the chance to have social workers added to their hospital or clinic to help them with a team-based approach to treat these patients. This is an example of a United States social work project. They developed for the Council on Social Work Education in America, PowerPoint slides on integrated healthcare that I've used for my training. The University of Washington in America has a model called the Collaborative Care Model that has very detailed resources on how to do integrated healthcare, especially staff training, the kind of resources needed to track patients, the integrated care model. And I found this resource just a couple of years ago. It's called Next Gen U, Next Generation University. This is a resource of treatment modules, very detailed, including instructions for the therapist, for the patient, handouts on treating many, many problems. It was developed actually by researchers in India and Africa. It has topics such as tobacco cessation, lifestyle medicine, substance use, depression. So a great resource that I often use this for additional information because it's designed for very practical training. So in summary, we're seeing an increased epidemic of COVID-19, non-communicable diseases, psychological, alcohol, drug problems. We know our current workforce of physicians and nurses are too busy, not trained to take care of these problems. We know that social workers are ideally suited to learn these skills and become a new workforce. And all we need now is to add training, education, and supervision for success, to move the needle and show over time we can add social workers to address these health problems. I know I covered many topics today. I want to stop and stop sharing my screen and happy to offer time to explain any of these ideas in more detail and answer your questions. So with that, I will stop my screen share and look forward to hearing any questions that you have. Thank you very much. I appreciate your courtesy in listening to me.
Thank you, Professor. It was really a wonderful session. It's a need of the hour. Social workers are, as you have rightly done a lot of research and stated. First thing is the lack of recognition and the cultural differences or the work difference, that is working with families and working with community, and capacity building, skill development. All these are there. Even the social work departments are also not adequately funded with the professors, and we have under capacities running with, and even most of the students also come from rural backgrounds. They have different challenges because most of the generations are either first generation or second generation students, and they have this language problem and lot of things are there apart from that. So this kind of module or training is very much required. It has to be integrated either into the social work education or can be taken as an additional module or an elective as part of the social work education, or can be taken up as a skill development initiative. Because in India we have skill development university also started. Maybe with that also it can go with the curriculum. So it's really wonderful. I personally would like to know more about this program. It's it looks more promising and very useful for the upcoming social workers.
Dr. Ravinda, a couple of things you mentioned are very important. The challenge is immense, right? This is a huge challenge, and there are many barriers. All the things you mentioned are so true: lack of recognition, lack of government funding, lack of curriculum. And I think starting small. For example, when I first started working in Beijing, China, I met with Ministry of Health for the local hospital, and that convinced them through presentations and chats to do a small pilot. I was able to train social workers there, where there was no funding, but they agreed to fund just a few social workers to learn these techniques. The doctors were trained how to work with the social workers. And over time, that became very effective. When they saw the impact, they then built in some regular funding, added more social workers, and that program is still continuing. But it was very difficult. It took months and months of meetings and persuasion to even get the small pilot approved. So the good news is there is hope. The challenge is it's a big challenge, right? It's very difficult. I don't mean for this to sound easy. It's very difficult, but I appreciate your positive feedback and happy to come back here someday and do maybe an example of one module so you can see in more detail what it looks like. I see a question in the chat box about engaging in mobile health. I mean, I think this is from Javier. I think you're talking about excessive use of screen time, screening on your phone all day, students not studying, adults not doing their work, using that to manage stress rather than using more appropriate techniques, the increase of bullying and shame among adolescents, even young adults. So I would not call it a disease, but certainly like any other habit, it can become a problem if there are consequences. If your child is being bullied and is depressed, that's a problem, right? If you're not doing your work responsibilities because you're too busy on social media, that's a problem. So like any other kind of habit problem, like overeating, like not enough physical activity, we need to take steps to replace the screen time with healthier behaviors. It doesn't mean screen time is bad, right? We all love our phones. It's a matter of, like everything else, moderation. Having time where your phone is not turned on, having time when it's not your constant focus of attention. So yes, screen time is an increasing problem globally that can also be addressed with these kind of techniques. I hope I answered your question correctly, Javier. Other questions, please, or thoughts?
Yeah, participants, feel free to unmute yourself, or you can put your comments, observations, or questions in chat box, or raise your hand. We will unmute yourself if you are unable to unmute yourself.
Hi, sir. Actually, very nice presentation. Lot of informative, lot of things. Yeah, you're given lot of learning. I learned, sir, and how you to do collaboration. I have seen you once, sir, in one of the collaborations with Nagraj. He had done one collaboration with Arizona University. I had seen you that time.
Yes, that's Nagaraju with Cyber University.
Yeah,
we've been planning for 1 year.
Sir, I had seen you. Now only I remembered, sir, that I've seen you once before. Actually, it's
happy to see you again, Mary. Happy to see you. Hope to see you all again. We're beginning now our training modules for Cyber University. We began last week. We're going to continue training through December. So I'll have a chance to see how well it's accepted and adapted. And keep in mind, when I do global work, I'm also the learner, right? I must learn from you about things I don't know about India, about the patient culture, about what kind of interventions work in India, about stigma, right? So I'm always a learner.
I also attended, sir, that collaboration with Nagraj. That's why I remembered you. Now I'm remembering you because he told my professors from Arizona University, sir, doing collaboration with me, attend Mary, he said. So I remembered, sir, that one. I saw you. The second time I'm seeing you, sir. Very informative presentation, sir. And please share your PPT, sir, to my email ID because I want to go through it.
I will send my PPT to you, Mary Florence. You may share with all the group here also, certainly.
Okay. Thank you very much, sir. Hope to see you in more sessions, sir. To come more often, at least once weekly, once like that you come. Sir.
Thank you, Mary. Thank you for the invitation. I see a hand raised by Shabnan.
Yes, Shabnam, you can unmute yourself.
Good evening, everyone. Thank you so much. It was a nice, informative session. Sir, I would want you to share your understanding and share your experience by how is it in your country there? I mean, are there funds, like we were talking about the barriers and how to negotiate those barriers? What kind of barriers are there in the so-called, like we say that it's a developed nation? So how is it in US? I mean, do you face these difficulties there as well? That there are problems with respect to funds, there are problems with respect to people, communities and groups have different mindset and not being open to, you know, care and I mean they have their own belief systems which are difficult to break. So if you could shed some light on that, sir. Thank you.
Thank you very much. So in the United States, because integrated healthcare has been a movement for over 10, 12 years now, it's becoming more commonplace and the barriers are much fewer than in India. So for example, in the United States, social workers can work in the primary care clinic and be reimbursed by the health insurance companies for their work. So it can be at least a little profitable. It can be sustainable. That's number one. There is a budget now for social workers in hospitals. You're seeing other kind of organizations hire social workers for the same roles. So that barrier is decreasing. Other barriers are similar, right? Many physicians still have, a big ego and don't think social workers are fit to practice in the busy medical practice, but we find for most, not all, once they work with a social worker who does not challenge them, but offers help, assistance, and resources, most physicians they change their view and see the social worker being more valuable to help them. You can survey, many studies show if you ask patients and physicians, are you taking your medication as prescribed? The patients will say maybe 75, 80%, no, I'm not taking it as prescribed. If you ask the doctor, are you taking medication? Are they taking the medication? They think, oh yes, my patients almost all taking medication as prescribed. They don't know most patients are not. And we have the social worker often talking to the patient, are you really taking medication? Why not? Is it not helpful? Do you not understand the reason? Is the dose not good? Are you having side effects? They become a consultant to help the doctor and patient work together. That's just one example of why doctors can suddenly see greater value for the social worker. And last of all, social workers in USA are often trained in psychotherapy, unlike in India, right? They're trained in cognitive behavioral therapy, mindfulness, so they have more basic training as part of their master's degree. They still need help on how to do screening, public health approaches in primary care, but they have an advantage there. So to answer your question, there's many advantages in USA compared to low and middle income countries or India. And the same thing for my work in China and Vietnam. In Vietnam, there's no budget. There's no training programs for social workers. This is the first one we're developing right now that we're going to put in place in the fall and publish a book in Vietnam on this topic. I should mention all the things I'm talking about, all these training can be done for other providers too. They can be done for psychologists, for physicians, for nurses. Anybody can learn these skills, but social workers to me seem the most identifiable and most the low-hanging fruit, right? They're there and they're ready to do this work, just need the training. Thanks for your question. Other questions?
Thank you so much. Thank you so much. I like you just mentioned that they have an upper edge because they are given training in psychotherapy and all. So what is the stance or what is the position of the psychologist there? Because if there is a provision for social work, I am assuming that the psychologist is already there in place before the social workers, being there. So how do they negotiate work there? So if you could share some more light on that.
Yeah. In the United States, most psychologists work in their own private practice or clinic, separate from the primary care. You're seeing increasingly psychologists also working in primary care clinics. But because there's such a great demand, there are so many patients, the turf wars are not a big deal. It's relatively rare for a psychologist to try and stop a social worker from doing this kind of work because they're both busy. They both have plenty of patients. There's no real competition. Especially since COVID, the demand for psychotherapy has increased tremendously in America, and there aren't enough psychologists or social workers to meet the need. So since COVID is even less of an issue, I'm a psychologist and I've worked with social workers throughout my career and see them as equals for most cases. Maybe I have more skills for highly complex cases, but for basic depression, anxiety, even post-traumatic stress disorder, for habit change, social worker training and experience is just as good as psychologists when they receive the right training. So that kind of barrier is not as sufficient, is not a big deal. I'm not sure that's a problem in India with psychologists not wanting to have social workers do work, but in America, that's not a big problem. I'd be curious to hear from you. Is that a problem in India? Do psychologists want to not promote social workers in this area?
Well, I being a psychologist myself, I would say yes. I totally agree with you that it is training experience really matters a lot. I mean, somebody is into psychiatric social work, somebody is into pediatrics or geriatrics. Their experience matters, and sometimes they can, the role can be overlapped. But then at the same time, I would say that somewhere I think all professionals are in need of trying to carve a sense of identity for themselves. So, and when I'm talking about this identity, it is not in terms of training and the nomenclature that, okay, I'm a psychologist, I'm a psychiatrist, and I'm a social worker. It also defines with the kind of maybe remuneration and salary packages that they get, and the way the government looks at them in hierarchy. I mean, in somewhere, if I'm able to share my views and understanding, is that like what you mentioned, that the doctors would look at themselves that a higher pedestal than a nurse, perhaps, from somebody that maybe they are very good with palliative care, supportive care, with their experience, but they would still say that we have a different role. I mean, I'm not denying that training, the kind of amount of education that they have, and the expertise and the nitty-gritties in which they train themselves, it is immense, it is completely laudable. But at the same time, I think the degree, what matters is where you have been trained. The milieu in which you've been trained is different, so if you could share your views on that. I mean, how is the state looking at it? I mean, and sometimes, I mean, from the perspective of the patient would not know. Sometimes they would even address somebody, because our country, literacy and education, I think that is there across the world. People would address anybody in position who is giving them knowledge, maybe Dr. Sahab. I mean, they give them respect. So it is not about coming from the patient perspective, unless until somebody is going to a very high-end hospital where there are cliche and differences being enumerated now, that there are people who are going to even super specialist doctors. I don't even want to go to a cardiothoracic a cardiothoracic cardiologist, or I mean, so there are super specializations. So I'm not talking about that patient, Your Honor, but I'm talking about the general patient who would give respect. But how is the state looking at it, and the community at large, the professional community at large, if you could share? Thank you.
Yeah, I think the best way to approach that is looking at scope of practice. what's your scope of practice? And there are many things psychologists are trained to do that social workers are not trained to do, and they should refer to a psychologist for those problems. Now, from an integrated healthcare perspective, most problems are not that complex. If you're talking about mild to moderate depression or anxiety, about nutrition, medical education, about diabetes, these are not very complex high-level skills. In fact, we know from the research, you can train even community health workers, lay people in the community with no educational background in healthcare to be effective at health coaching for mild to moderate problems. And for the scope of practice, things that psychologists do, like long-term psychotherapy for complex cases, maybe suicide management, any kind of psychological or neuropsychological assessment, managing complex conditions like schizophrenia, medically resistant treatment, depression. There are many things that psychologists are trained to do, or psychiatrists for that matter, that social workers are not trained to do and would not be expected to do in this model. So there's a respect for scope of practice. And secondly, I think your question was about other professionals' view. Typically, once a social worker is trained and begins working side by side with the other professionals, psychiatrists, physicians, psychologists, people find their role and value each other, and there's less competition, less animosity. Once there's a chance to learn from each other, once there's a chance to see, oh, the social worker can screen for depression, they can treat the mild to moderate cases, they can give me a psychologist the more difficult cases. And last of all, there's a role for psychologists and senior social workers to become trainers and supervisors. They can help train a new workforce of social workers or community health workers in these techniques and approaches. So given the demand being so high, there are so many patients who need help, that's been a way to overcome some of these professional guild barriers in the United States and other countries I've worked in. Does that make sense? Did I answer your question?
Thank you so very much. And it's a very sensitive question that I posed. But thank you to the organizer, Ravinder sir, also, and you taking it so positively. Thank you. Thank you.
When I first launched the Doctor of Behavioral Health degree, we were enrolling social workers and had them become doctors. They weren't psychologists, but I was invited to go to the psychology board of my state and explain what this degree was. At first, they were very upset and angry. You're going to try and, take over our job. When I explained the role of these doctoral social workers is not the same scope of practice. It's complementary. And it's kind of work most psychologists don't want to do. Most psychologists don't want to do working in primary care clinics, working with the patients on this kind of population approach. So education, understanding among our professionals is very important. And I do agree that patients they don't really care. If you can provide them help, whether you're a psychiatrist, psychologist, social worker, you're valued by the patient if you can offer help. So I also agree with that statement. I have a few more minutes. Any more other questions, please? I need to finish in about 5 minutes for my next meeting. Any other questions? Happy to answer one more.
Thank you, Professor. It was very well stated. Let me share my observations in CRISP. I also work with the medical fraternity as an interdisciplinary, multidisciplinary team. I am part of the surgeons and consultants, even the case managers and all, as an integrated team. So when we see as you have rightly pointed out, we often cross our boundaries when we are doing practice. That is where, definitely the medical professionals, the doctors are on the higher rank because of their qualification, experience, and because of the scope of work they do. But often when we cross these boundaries, especially, that is where we get into conflict of them, and that professional ego starts between them, and there are a lot of disagreements between this thing. So I have seen very good professionals, medical doctors, who have welcomed psychologists, social workers, and I'm fortunate to work with such medical professionals, senior surgeons, those who actively welcome. In fact, they say that we need persons like you to help us, because the amount of patients we get And the time we have, we are really stressed out with this. We just wanted to take a break and take a nap, but we don't really find someone helping hands for us. You are doing a wonderful job as a psychologist, as a social worker. So, I mean, with that, we need to understand, as you rightly said, the scope of work. We should not cross our limits. We should not cross our boundaries. And in medical profession, we have super specialty, super specialties, subspecialties. But in psychology or in social work, if you see the educational curriculum, the courses offered in universities, we don't have such kind of super specialties or subspecialties. Hardly we have 5 to 10 specializations across India. More than that, we don't even have, and they are also not purely clinical in nature. So that also poses challenges when we are working with a very well established disciplines like medical council or pharmacy council, which have a lot of, ethics and code of conduct and this training that that is put in place with stringent protocols. But we as a social worker or we as a psychology, we don't have even a board to govern these professions. We don't have standards set by a council. So a lot of challenges are there that makes them unless they are they have this experience of working as an individual rather than as a professional body, they definitely have this kind of doubt about the competencies, as you rightly said. There is no one to certify this social worker is competent or this psychologist is competent. There is no body that certifies them. Everyone gets a degree and calls himself as a psychologist or calls himself as a social worker. So, but in medical profession, Medical Council of India is there who certifies and regularly controls, governs. But that is the main drawback for social workers or psychologists or counselors we are facing. Maybe that also due to various reasons are not moving forward in a positive way, but we still have hopes that one day or other we will be getting recognition. A recent Allied Health Act also has provided some sort of legal relief, but still that identity crisis, identity as a psychologist, identity as a social worker, and that too identity as a clinical social worker is a long way to go unless and until we really work on that. Maybe as rightly, maybe the day has come that we have met on this platform, and maybe the program which you are running, integrated concept, a module, can be implemented at the earliest, so that we can produce some competent social workers and can show them as a role model that yes, we can show, we can have a baseline that yes, this is a kind of capacity building or the capacities or competencies of a trained social worker, at least in some specialties, like you have said, community health, preventive health aspects, or chronic health. So maybe this is a very promising program. Hope to collaborate with you, and so maybe we can have a program soon, and we shall see how best we can contribute to the profession. And we really thank you, Professor, for joining us, and it was really enlightening session.
Well, thank you, Dr. Ravindra. You made some great points there, and you know that you're correct, especially that having no professional association to advocate is a big barrier. So the road ahead of us is a long road, full of holes and obstacles. And let's hope we can just move forward and make small progress. Maybe some pilot projects, right? Maybe a small grant-funded project to show proof of concept. But it's important to recognize it's a long, hard road ahead. No reason not to fight and keep on trying, but we must recognize it's not going to be easy. So I do thank you for your feedback. It's very warm and welcoming.
Any other participants, if you have any queries, quickly we can take one or two if time permits. Otherwise, we shall conclude and relieve Professor for his meeting. Okay, there are few appreciation messages, but I don't see any queries. So thank
Very
you,
good.
Professor. Once again, on behalf of Sri Holistic Health Foundation India and Sri Research Institute and Center for Arts, Sciences and Wellbeing, and also on behalf of all the participants, we thank you and we eagerly look forward for collaborate for launch of this program. I'm very much interested. I will contact you later. So
I like
we will
that.
work out on to roll on such a program, at least with couple of social workers who are really interested in this. Maybe
That
that
sounds great.
can be a baby step for our future, better future.
Okay, my colleagues, have a good night. Thank you for your time and attention. I hope to see you all again.
Thank you.
Bye-bye, all.
Have a great day, Professor.
You too.
Take
Have a
care.
good evening.
Yeah, after a wonderful session by Professor Ronald R. Donnell, it's a need of our that we need to improve our competencies and also the teamwork, especially when we are working with multidisciplinary team. It is very important that there are thin line boundaries. We should recognize and respect each other's boundaries. Often we see that this lack of recognition, professional councils for various professions like psychology or counseling or social work. So and governing councils or bodies. So that kind of professional recognition is lacking. So we need to work on those lines to have some council or a body which is acceptable for everyone. Though the efforts are going on, but everyone is not able to actively collaborate, cooperate, and coordinate the efforts. That's why we have seen many times efforts are being put, but unfortunately we see a less amount of outcome.
Professor, good evening.
Yeah, good evening.
I'm Dr. Venkaya. I represent I'm the Vice Principal in G. Popularity College.
Nice, sir. Welcome, sir.
I am also member and region chairperson in Lions Club.
Nice, sir.
We usually do social work through Lions Club itself. Anything is required, I will also associate.
Sure, sir. Definitely, we look forward. Maybe you can join one day, sir. You have, I think you have my contact number. You can just take a session on any one particular day, and you can explain about various activities that is being carried out. No? So that will help everyone, and also we will also see how we can collaborate and organize more activities.
Sure, sir.
Thank you, sir, for sharing your feedback. Today, we are also commemorating Micro, Small and Medium Sized Enterprises Day. So we'll briefly look into these things and then we'll close the session. And we are also commemorating Helen Keller's day today. Helen Keller is from United States. Is an American author and disability rights advocate, political activist, and also lecturer. Actually, she lost her sight and hearing after a bout of illness at the age of 19 months. And she then communicated primarily using signs until the age of 7. So when she met her first teacher and lifelong companion, Annie Sullivan, the young woman taught her Keller the sign language, including reading and writing. After an education at both the specialist and mainstream schools, Keller attended Radcliffe College of Harvard University and became the first deaf-blind person to earn a Bachelor of Arts degree. So she worked for the American Foundation for the Blind from 1924 until 1968. During this time, she toured the entire United States and traveled to 35 countries across the globe advocating for those with vision loss. So Keller was also a prolific writer, writing 14 books and hundreds of speeches and essays on topics ranging from animals to Mahatma Gandhi and so on. Keller campaigned for those with disabilities, for women's suffrage, labor rights, and world peace. In 1909, she joined the Socialist Party of America. She was a founder member of the American Civil Liberties Union. Keller's 1903 autobiography, The Story of My Life, publicized her education and life with Sullivan. It was adapted as a play by William Gibson, and this was also adapted as a film under the same title, The Miracle Worker. Her birthplace has been designated and preserved as a National Historic Landmark. Since 1954, it has been operated as a house museum and sponsors an annual Helen Keller Day. And Keller was inducted into the Alabama's Women's Halls of Fame in 1971. She was one of the 12 inaugural inductees to the newly founded Alabama Writers Hall of Fame on June 8, 2015. She has contributed through various lectures, through various writings, and when we look at formal education in May 1888, Keller started attending the Perkins Institute for the Blind. In 1894, Keller and Sullivan moved to New York to attend the White Humanson School for the Deaf and to learn from the Sarah Fuller at the Horace Mann School of the Deaf. In 1896, they returned to Massachusetts and Keller entered the Cambridge School for Young Ladies before gaining admittance in 1900 to Radcliffe College of Harvard University, where she lived in Briggs Hall, South Oaks. Her admirer, Mark Twain, had introduced her to the Standard Oil magnate Henry Hutchinson Rogers, who, with his wife Abby, paid for her education. In 1904, at the age of 24, Keller graduated as a member of Phi Beta Kappa from Radcliffe, becoming the first deaf-blind person to earn a Bachelor of Arts degree. She maintained a correspondence with the Austrian philosopher and pedagogue Wilhelm Jerusalem, who was one of her first to discover her literary talent. Determined to communicate with others as conventionally as possible, Keller learned to speak and spent much of her life giving speeches and lectures on aspects of her life. She learned to hear people speak using the Tadoma method, which means her fingers to feel the lips and throat of the speaker. She became a proficient at using Braille and also using finger spelling to communicate. Shortly before World War I, the assistance of Zolan Quartet, she determined that by placing her fingertips on a resonant tabletop, she could experience music played close by. And she was very much active in political activities, and Sullivan, his teacher, her teacher, was very much committed and dedicated and contributed to the Keller's development. So Keller wrote a total of 12 published books and several articles. One of her earliest pieces of writing at age 11 was The Frost King. There were allegations that the story had been plagiarized from The Frost Fairies by Margaret Canby. At age 22, Keller published her autobiography, The Story of My Life, with the help of Sullivan and Sullivan's husband, John Massey. It recounts the story of her life up to the age of 21 and was written during her time in college. In the article, Keller wrote in 1907, she brought to the public attention the fact many cases of childhood blindness could be prevented washing the eyes of every newborn baby with a disinfected solution. At the time, only a fraction of doctors and midwives were doing this. Thanks to Keller's advocacy, this common sense public health measure was swiftly and widely accepted. And Keller wrote The World I Live in 1908, giving readers an insight into how she felt about the world. Out of the Dark, a series of essays on socialism, was published in 1930. When Keller was young, Annie Sullivan introduced her to Philip Brooks, who introduced her to Christianity. Keller famously saying, "I always know he was there, but I didn't know his name." Her spiritual autobiography, My Religion, was published in 1927 and then in 1994 extensively revised and reissued her under the title Light in My Darkness. It advocates the teaching of Emanuel Swedenborg, the theologian and mystic who gave a spiritual interpretation of the teachings of the religious and who claimed the second coming of the religion and religious head come back. And Keller, in her later life, had series of strokes in 1961 and spent last years of her life at home. On September 14, 1964, President Lyndon B. Johnson awarded her the Presidential Medal of Freedom, one of the United States' two highest civilian honors. In 1965, she was elected to the National Women's Hall of Fame at the New York World's Fair. So Keller devoted much of her later life to raising funds for the American Foundation for the Blind. She died in her sleep on June 1st, 1968 at her home, Arkenridge, located in eastern Connecticut, a few weeks short of her 88th birthday. The service was held in her honor at the Washington National Cathedral in Washington, D.C. Her body was cremated and her ashes were buried there next to her constant companions, Annie Sullivan and Polly Thompson. So this was brief in her about her life. So she has contributed a lot to the deaf and blind, and today every college, every student remembers her and commemorates her birthday as the most important contribution to the deaf and blind population. And today we are also commemorating Micro, Medium, Small Size Entrepreneurs Day with the theme Resilience and Rebuilding, MSMEs for Sustainable Development at the forefront of building back better and stronger from the impacts of COVID-19 pandemic and climate crisis conflicts. The United Nations General Assembly designated 27th June as Micro, Small and Medium Enterprises Day to raise awareness of the tremendous contributions of micro, small and medium-sized enterprises to the achievement of the United Nations Sustainable Development Goals. 600 million jobs will be needed by 2030 to absorb the growing global workforce, which makes SME development a high priority for many governments around the world. In emerging markets, most formal jobs are generated by the SMEs, which create 7 out of 10 jobs. Increasing annual investments in small and medium-sized enterprises by $1 trillion would yield disproportionate dividends in terms of progress towards the sustainable development goals. Small firms in developing countries are among the most concerned about climate change. 68% of the companies in sub-Saharan Africa say that environmental risks are significant to their business, according to the research by the International Trade Center, ITC. Half of surveyed companies in the developed countries say the same. So MSMEs account for 90% of the businesses, 60 to 70% of the employment, and 50% of the GDP worldwide. As backbone of societies everywhere, they contribute to the local and national economies and to sustain livelihoods, in particular among the working poor, women, youth, and groups in vulnerable situations. This year, the International Trade Center ITC marks the 5th anniversary of the MSME Day, and small business are more than ever in need of support as they navigate the impacts of COVID pandemic, conflicts, and the climate crisis. They are the hardest hit by these multiple shocks and at the same time play a crucial role in building back stronger. MSMEs have to become more resilient to future shocks, and efforts and stimulus packages must target those most heavily affected by disruptions to global supply chains, rising inflation, and the counting ramifications of the COVID-19 pandemic. Policymakers must move beyond recovery and consider ways in which to lower, eliminate barriers faced by MSMEs, improve the business environment, and access to finance, markets, and technology in these fragile times. It is critical that countries and their development partners continue to support and empower MSMEs and unlock their full potential through inspiring innovation, creativity, and decent work for all. So the importance of MSMEs for the Sustainable Development Goals, 8th goal, decent work and economic growth. Micro, small, and medium-sized enterprises are vital in achieving the Sustainable Development Goals. They are an important element in the implementation of SDG Goal 8, decent work and economic growth, and SDG Goal 9, industry, innovation, and infrastructure. So from export development to sustainability or e-commerce and export processes, the International Trade Center offers a wide range of courses that can help MSMEs in their growth. So with this, the importance of MSMEs can be lauded. And as we have already seen, micro, small, and medium-sized enterprises, commonly abbreviated as SMEs, are responsible for more than 2/3 of all jobs worldwide. They also account for majority of new job creation. But despite providing a huge share of global employment, MSMEs still face major challenges when it comes to working conditions, productivity, and informality. So the small and medium enterprises or SMEs typically have fewer than 100 or 50 employees. In many countries, more than 90% of all enterprises can be classed as SMEs, and a large share of those can be classed as micro firms with fewer than 10 employees. While they may be small individually, the new ILO data shows that International Labour Organization recent data show that micro and small enterprises together with own account workers account for a staggering 70% of the employment worldwide as we work to achieve the UN Sustainable Development Goals and the International Labour Organization's recent work agenda. We cannot afford to ignore the potential SMEs and challenges they face. And they are also the engines of development. Worldwide, when we say the employment share by the enterprise size and the self-employed around the world, we see self-employed person 32.8% and micro enterprises 2 to 9%, 23.1%, and small enterprises that 10 to 49%, 14.3%, and medium and large enterprises 50+% are 29.8%. That is worldwide. If you see in India also, we have similar figures. And across all countries, SMEs do more than creating employment. They are also engines of economic growth and social development. In most OECD countries, SMEs contribute more than 50% of the GDP, and some global estimates put the figure as high as 70%. This contribution varies across sectors and is particularly high in the service industry, where SMEs account for 60% or more of GDP, nearly all OECD countries. SMEs are also more likely to hire from groups with lower chances of finding employment, such as young people, older workers, and less skilled workers. So SMEs are crucial to the future of work, not just for employment creation and economic growth, but also to drive innovation, competition in markets. But large enterprises can invest more in training and equipment, pay higher wages, and offer better working conditions. So outmatch SMEs when it comes to the productivity and quality of employment. In developing countries, this productivity gap leads to low income generation, informality, and poor growth performance. To close this gap, we must first understand the problems faced by SMEs, both from the perspective of employers and employees, and in the context of broader challenges facing by the world of work. When we look at the innovation and productivity, large enterprises tend to be more productive and innovative, where we can see relative to small enterprises, the difference is in higher labor productivity 62%, higher wages 50%, higher chance of being an exporter 23%, more likely to add new product lines 19%, and more likely to incorporate new technology 18%. So thus large enterprises have an added advantage over this SMEs. So we need to support them. And when we see that lower productivity levels, we see in countries like Mexico, Turkey, Greece, Republic, Portugal, Poland, Hungary, Brazil, Spain, Italy, Netherlands, Israel, France, Finland. We can see in these countries, the average is 52 to 49% employed in each SME. And when we look at the wage gap, we can see the world average is 143, with medium enterprises between 20 to 99 employees, and large enterprises which has more than 100 plus employees, the wage index is 200. So large enterprises are more likely to pay higher wages. But still, when we look to the contribution of economy and the GDP, 70% of the contributions comes from the small scale industries, that is SMEs. So running the employer's perspective, when we look at running a small business can be challenging even in favorable conditions. But when the business environment is stacked against you, the productivity and innovation suffer as a result. And the research shows that the biggest challenge for the employers include regulatory environment, access to finance, skill shortages, access to infrastructure. So needlessly complex and unpredictable rules and regulations and support structures create barriers for small firms and impede their growth. And SMEs frequently face higher transaction costs and interest rates than larger enterprises, limiting their ability to obtain external financing. So skill shortages, SMEs suffer skill shortages both at managerial and workforce levels. Lack of resources, knowledge, and fear of poaching mean that SMEs are less likely to invest in the workforce training. And small firms often cannot access basic infrastructure such as clean water, roads, and electricity. They are also often excluded from business and employer networks and do not have the resources to make use of new digital technologies. And the workers' perspective, when we look at the SMEs score lower on most aspects of employment quality when compared to larger enterprises. For their employees, the biggest challenges are lower wages, lack of social security, poor occupational safety and health, and weaker industrial relations. So in European countries, wages in SMEs are 20 to 30% lower than the national average. Findings are similar in Japan and the United States. In addition, the gender wage gap between the male and female owned SMEs persists globally. And in many low and middle income countries, small firms are not required to contribute to social security coverage due to low number of employees. In addition, many SMEs operate in the informal economy and so do not provide any social security to their workers. And research finds that work environments are more hazardous in small enterprises than in larger ones. In Europe, 82% of all occupational injuries and 90% of all fatal accidents occur in SMEs. And industrial relations and collective bargaining play an important role in improving employment, security, and also working conditions. However, in SMEs, trade union membership is low and company level collective bargaining is often non-existent. So when we look at the whole greater picture, the world of work is in the face of major uphill and many challenges, both old and new, are hitting SMEs particularly hard. But with the right perspective, a challenge can become an opportunity. So the International Labour Organization Human-Centered Agenda for the Future of Work gives us the key to channel disruption into positive change. These are going green. Environment sustainability cannot be achieved without SMEs. So in addition to their impact on the environment, they also hold the key to designing local solutions to climate change. But for many small enterprises, the process of greening the business is limited by additional costs and lower awareness. By raising awareness about the benefits of going green and equipping small enterprises with the skills they need to get there, we can achieve a just transition to environmentally sustainable future. And women's entrepreneurship. Women own and lead up to 1/3 of all business operating in the formal economy worldwide, and millions more run small informal enterprises in developing economies. So women continue to pursue entrepreneurship and succeed in business in spite of the barriers they face, including discrimination and harassment at work, the lion's share of domestic responsibility, and of course, a persistent gender pay gap. Imagine what they could achieve on a level playing field. The informal economy, The major of SMEs are also informal enterprises which provide livelihoods for 60% of the world's workers. Unfortunately, informal employment is typically characterized by low pay, poor working conditions, and lack of social security. Productivity also tends to be low, and these enterprises often cannot access finance and markets, reinforcing their informal status. By creating paths to formality and sustain productivity growth, we can create more and better jobs, improve public services by broadening the tax base, and create an overall culture of good citizenship and compliance with labor laws. And rapid digital development is a major disruptive factor across all sectors and industries. For SMEs, digital technologies can potentially enhance management practices, improve market intelligence, and create virtual access to regional and global value chains. However, many SMEs lack the skills and resources to capitalize on this opportunity. By supporting SMEs in the transition to digital, we can ensure that small business can benefit from the full potential of new technologies while simultaneously ensuring that digital adoption does not compromise decent work. So helping SMEs flourish by providing training at all levels, supporting entrepreneurship, fostering an enabling environment, and creating access for vulnerable populations. So this can be achieved by starting and improving businesses, women's entrepreneurship development, enabling environment for sustainable enterprises, sustaining competitive and responsible enterprises. And no business exists in vacuum. A value chain describes how the value is created by the enterprises, activities, and other actors need to bring a product from initial idea to its final market. So we need a systematic approach to value chain development by identifying and removing underlying causes of market underperformance to create benefits for actors at every point in the chain. Strengthening value chains increases profits and productivity for SMEs, which allows them to create more and better jobs in their communities. In turn, this approach ensures sustainable growth and greater benefits for the poor. And the ripple effect. The International Labour Organization is campaigning a human-centered vision for the future of work. This means reaffirming that the labor is not a commodity and keeping the rights, needs, and aspirations of the people at the heart of every program and policies. By supporting SMEs to meet and overcome many challenges they face, the ILO is improving and the livelihoods of the people who run them, those who work for them, and everyone who relies on the products or services SMEs provide. Supporting SMEs creates far-reaching ripples of positive effects for families, communities, and countries. The future is small, but the future is beautiful. Leaving SMEs behind is not an option. The 2030 Agenda for Sustainable Development certainly cannot be achieved without them, given their global prevalence and their huge importance to social, economic, and environmental development. The future of work will be bleak if we do not support SMEs to unlock their full potential. But once we start taking big steps to support small enterprises, the future looks bright and beautiful indeed. So with this, we shall conclude. If you have any queries, feel free to discuss. If you have any observations or feedback, feel free to share. Okay, there are no queries. We shall conclude. Kindly find the feedback form link in the chat box. Fill up the feedback form. certificate will be provided within 15 working days on the website. You can find the download link on the website from where you can download your certificates. Some of the participants were asking today in WhatsApp. So let me demonstrate you from where you can download your certificates. Quickly, I will take 1 or 2 minutes. This is the website which is available in the registration message and also registration forms and also on the flyer. You can type this, it's a very short address. It's very easy to remember. Once you open the website, you can scroll down. Here all these webinars are part of international webinar series on holistic health, well-being and sustainable development. So you can click on this. So it will be taking to another dedicated website, which is part of this only, or you can directly type this address. It is also available on the flyer where you can directly type this address also, or if it is difficult to type a lengthy address or remember, you can always use a short website. Here you can see on the left side, for the convenience, we have divided all the webinars into 3 categories. So one is weekdays and the other is Sundays and special days. So here weekdays, when you click on the weekdays, you can see all the series from the first webinar till today. You can find all the webinars. You can just click on today's webinar. Today is 27th. Here is a flyer for today's webinar. So below that, here, sorry, that's May, 27th June. Yeah. So this is today's flyer. You can navigate here from that. You can select any even previous webinars also if you have attended, and upcoming webinars all are listed here. You need to just select the date, whichever webinar you have attended. This is today's 27th June. And you can find the flyer. You can reconfirm yourself. See, in the flyer also it's mentioned. The website address is given. Here, webinar series website is mentioned. Otherwise, we have mentioned the website address also. All the details are available on the flyer. And also we have mentioned about the certificate also, that within 15 working days after the webinar, certificate download link will be shared on the webinar website. Now just below this flyer, you will find this link. Here the link will be updated within 15 working days. That is maximum time. Generally, we don't take much time. But whenever, as early as possible, we will update it. Here you can download. You will find a link where you can download your certificate. So let's see any previous webinar where you can find the link. So this is this month, 27th. Let's somewhere around 18. See, here you can see the Google Drive link. Once you click on that, you can find the certificates. In a similar way, even if you have attended Sundays also, Sunday generally these are 2 hours or 1 hour program. For Sundays it's a full day program. See, all Sunday webinars, conferences are listed here. This was yesterday's. Here you can find the flyer. You can download link will be provided here. Last Sunday you can see 19th. Just below the flyer you will find this link to download. So once you click the Google Drive link, you will get all the certificates here. You can see all the certificates are available here. You can select your, every certificate is uniquely identified with a certificate number, ID and your name. You can just click on, you can find your name and you can click on the certificate and you can download. There is a download option. Otherwise you can open it also. And here you will get a download option. You can download it. So in similar way, daily you can attend. The link is same for every day. For all the events, the link is same. So save the link. And you can register daily and attend. So don't worry about the certificates. Certificates, whenever they are issued, they are updated on the website. They will be there for that. So whenever you want certificates, you can download it from there. You can keep attending daily sessions. Daily sessions are being conducted from 6 to 8. And on Sundays, it's from 11 to 5. So keep joining us, and for all the updates, do join our Facebook group and Telegram channel, where we will be posting daily day-to-day flyers and information, registration forms, and also updates whenever the certificates are issued. So we are occasionally, not daily, occasionally we are posting them. So you will get all the updates. So it's easy. So kindly share with your friends. These are entirely free. If you are an expert, subject experts, and you would like to share information, you can contact us. You all have my contact number, or otherwise on the website or on the flyers in the registration message, you have my contact number. You can WhatsApp me your details and your domain expertise and the topic you would like to deliver, and we are happy to schedule your session. So this is our platform. Share the registration forms with your colleagues, friends and circles, and see you kindly fill up the feedback form before you leave. It is mandatory to issue certificate. So see you all tomorrow. Take care. Good night. And we thank you all, one and all, on behalf of Sri Holistic Health Foundation India, Sri Research Institute, Center for Art, Sciences and Wellbeing. We wish you all the success. Take care. Good night.